And finally, Dr. Jones.
Thank you very much to the committee. It is an honor to be here. So I am going to be talking about product labeling to communicate benefits and risks with the treatment for opioid use disorders in pregnant women. So the window with which I view the world is as a psychologist and as an executive director and person who takes care of patients in a comprehensive care program for pregnant and parenting women and their children. I've also done, as the introduction said, a number of research studies with methadone and with buprenorphine that are specific medications to treat opioid use disorder. So with the time that I have, I'm going to do two things. One is review the historical and current context of drug labeling for pregnancy and lactation, and then also highlight some of the challenges and opportunities we have with the current labeling information that we have with opioid agonists to treat opioid use disorders during pregnancy and the lactation period. So I'd like to start with context and put this issue in a historical context, and I don't think anybody's talked about this yet today, in terms of the FDA and pregnancy labeling. So we used to think, way back in the day, that the placenta was actually a barrier to prevent drugs or other substances getting into the fetus. With thalidomide, we know very keenly that that was not the case. And that took a tremendous amount of attention onto pregnant women and the potential for birth defects that could happen when women were given medications. The next kind of important thing, for sake of time, that the FDA did with pregnant women was in 1973, when we had methadone to treat opioid use disorders, they were concerned about pregnant women receiving methadone. So they said, basically, all pregnant women on methadone need to be detoxified within 21 days. There were a couple of case reports and there was alarms that went to the FDA, and they subsequently reversed that decision. And so now it is recommended that opioid-dependent women can be maintained on methadone. Moving forward, in 1979, we had the FDA really started looking at medications and pregnancy and how they could do a better job of labeling. By 1997, we had a hearing to review the alphabetical categories of A through D and then X, and the emphasis there was really on teratogenic effects. And so I think that there was, in terms of communicating labeling, there was kind of a false reassurance that medications in A were perfectly okay. The vast majority of medications are in category C, which I kind of think of as use at your own risk. We don't have adequate data. In 2013, there was a letter to the FDA by the National Associations of Attorney Generals that we're going to talk a little bit more about, and that was around neonatal abstinence syndrome. And the FDA responded, and we have a special boxed warning about neonatal opioid withdrawal, is what they called it. 2015, we finally got rid of the alphabetical categories, and now we have a different pregnancy and lactation labeling rule that started. And then finally, the FDA required that our opioid agonist medications to treat opioid use disorders, methadone and buprenorphine, to have safety labeling around the neonatal opioid withdrawal. So there was a lot of attention to what has traditionally been called neonatal abstinence syndrome. So let me just define that for you. It is a condition of signs and symptoms that include central nervous system dysfunction. So babies are irritable, they have tight muscles, they can have tremors, they have difficulty with their sleep-wake cycle. Autonomic nervous signs, so sweating, fever, stuffiness. Gastrointestinal distress, these babies can be difficult to feed and difficult to soothe. They can have high caloric needs, and then signs of respiratory distress. What's really important on this slide is that neonatal abstinence syndrome is an expected condition and it is treatable. We have good tools to assess it. We have good medications to treat it. Another really important thing is was the FDA that started with the product labeling around the neonatal opioid withdrawal syndrome. And in that context, I can understand it because they wanted to be very prescriptive or clear about the opioid withdrawal. But the traditional term has been neonatal abstinence syndrome, and that is language that is throughout the literature that we have. And we also know that neonatal abstinence syndrome is not just about opiates. Yes, opiate is an important factor, but we know that we have women that have been maintained on these medications. Their babies don't have a withdrawal that needs to be treated. So what we need to look at are the factors that drive the severity or the reduction of that abstinence syndrome, which include genetic factors, the severity of smoking, and the protocols that hospitals use to treat the babies. So for example, rooming in is one of them. We can cut the treatable NAS rate in half if we have mom and baby stay together. Breastfeeding is another example. So I want to drive home the fact that there are multiple factors that drive the severity or the reduction of NAS. The other important thing is because NAS is treatable, we have data to say that just having a neonatal abstinence syndrome or being treated for a neonatal abstinence syndrome does not, in and of itself, predict long-term good or poor outcomes. What we know is the most important piece is the postnatal environment in which the child grows up in. And yes, there is an interaction between a baby that has NAS that needs treatment and the mother or the caregiver that can exacerbate negative impacts, but it is, or improve the resiliency. So it's really, it's not so simple as neonatal opioid withdrawal. So moving on, this is what the labels used to look like before we had the NALs. And it was, this is just an example of dolphin. And you can see infants born to mothers physically dependent on opioids may be physically dependent and may exhibit respiratory difficulties and withdrawal symptoms. Now there's no, like the previous speakers talked about, there's no quantification of that, but it also sounds like this is an expected and treatable condition. Then we had the letter to the FDA by the National Association of Attorneys General. This letter had 44 signatures. When the Hydro letter came out, it had a handful of signatures. And I think that really drives, when we're concerned about an epidemic and the opioid crisis that we talked about this morning, there's just a tremendous amount of fear and attention given to neonatal abstinence syndrome. What they asked for was basically a boxed warning on the label. And there were letters, even though this was really focused on pain medication, there were letters from the American Society of Addiction Medicine, from ACOG, the College of Obstetrics and Gynecology, and the National Advocates of Pregnant Women, warning about unintended consequences of such a black box warning. They talked about it could reduce the number of pregnant women with opioid use disorders getting treatment. They talked about discontinuation of treatment, kind of like what we saw in the 1970s, or that women would be removed from opioids altogether or not being given them. The labeling could also be used to justify punitive or counterproductive welfare interventions for the children, and women could avoid seeking prenatal care or treatment. Here's what the labeling language that the FDA approved. So all drugs, it doesn't matter what drug it is, as long as they're the extended release long-acting opiates, need to have this language there. And so you can see that there's a tremendous amount of a description of the withdrawal terminology. And the other important piece is that it says it may be life-threatening if not recognized and treated. And I'll go back to that in just a moment. So then moving forward to the FDA labeling around methadone and buprenorphine, here's a practice advisory from the American Academy of ACOG. And this gives you exactly what a black box warning is, which it's the strongest warning that the FDA can provide to provide caution against around the medication, the use of the medication. And so what I think is that there are a couple of unintended consequences that are really important for us to review. In the first category is around NAS. The warning really emphasizes the potential risk, and I think it overemphasizes the risk of unexpected or unrecognized neonatal abstinence syndrome. And it would be really nice to have that quantified in some way, because it doesn't make a distinction between recognized and unrecognized. So there are also concerns around this unexpected or unrecognized. How are we going to identify women who might be using these opiates? So the whole identification is really a separate process than being maintained on the medication itself. Opiate use clearly contributes to neonatal abstinence syndrome, but how we're going to identify the women is separate. And finally, the opposite of the intended effect of the FDA's new labeling rule is basically asking for identification, unifying or a universal testing, which has a whole host of risks and benefits in and of itself. In terms of impact care for pregnant women, patients could be denied access from these medications that could either be for pain or could be for opioid use disorder, or they could be abruptly discontinued from the medications. The box warning was specifically assigned to immediate release formulations, but there are women that might need them for acute pain during pregnancy, for labor and delivery, for trauma, for injuries that they might have had, and it could be an appropriate use for a short period of time. And finally, it could also negatively impact the appropriate use of those medications. In terms of mothers and children, the box warning might be used against women in a criminal kind of proceeding, or used against them to say that this is evidence that they're supporting termination. So the new label requires a pregnancy exposure registry. And from a 10,000-foot view, that seems really good. We want as much information as we can on as many women who are being exposed to these types of medications. My concern is it is going to take years. We're going to have to collect enough information that we can actually make accurate determinations of true risk and any benefit. It's also biased. These registries are biased against adverse events being reported. So we only know half of the football score. We don't know what both the numerator and the denominator really are. So my recommendation is that we need to put money and support into having prospective trials sooner rather than later, because pregnant women, just like all people, deserve to benefit from medication advances, or we need to know sooner rather than later if there is a problem so we don't have such mass exposure over so many years. My final kind of concern that I would like to lay out there is the concern around birth defects that have been associated with opiates. This was a very highly publicized paper by the CDC, and where we do see that there was a statistically significant increase with women who are taking or prescribed opioid pain medications during pregnancy. You can see that there were these birth defects. But I think it's really important that we look at relative risk as well as absolute risk. We know that birth defects occur in 1 in every 33 births in the United States. So that's not to say that these aren't important data, but we want to make sure that we're communicating the risk accurately to pregnant women or women who are considering getting pregnant. And there was a whole number of other limitations with this study that, for sake of time, I won't go into, but other than just to say that we need to be really careful when we're communicating studies and also include the limitations of them. So my suggestion, and I don't have the pretty tables that the previous speakers did, but my suggestion is to provide in the label risk and benefit information for all phases of pregnancy. Because I think about a physician sitting there with the patient, and they're going to care about preconception. What do we know about that? Can we quantify that with the medication? All 3 trimesters. What happens in the first trimester, the second trimester, the third trimester? What about labor and delivery? What about postpartum and lactation? And so my idea of a table is that you would have risks and benefits for the mother and risks and benefits for the embryo, the fetus, and the neonate. So we're not separating mother versus embryo, fetus, and neonate, but we can look at it together. So in summary, I think that the box warning overemphasizes the negative risks of neonatal abstinence syndrome with limited acknowledgement that there are even greater risks associated with abrupt cessation of such medications during pregnancy. I think the labels need to be more easily updated so that as data come out, it's quantified in those nice boxes that the previous speaker talked about, but the benefits as well as the risks are also there. We need to answer questions about the unintended consequences of box warnings. I showed you the letters, their concerns. We need data to support or refute those. And I think we need to be very carefully looking at the language that is used to convey those warnings. The idea of death and unintended and those sorts of consequences, let's quantify that. It is incredibly rare in this day and age that we have deaths from neonatal abstinence syndrome. I think it's been like 100 years since we actually had a death due to not being treated for neonatal abstinence syndrome in and of itself. Yes, there have been reports of harms to children that have been exposed to opiates that have gone home with parents, but in terms of neonatal abstinence syndrome, I think that that is an overestimation of the risk. And finally, I'll reiterate again that we need those resources that are devoted to prospective trials so we can know sooner rather than later about the harms and benefits and not wait for decades of a slow trickle of data to come in. And I want to acknowledge Dr. Michael Green, who shared some of his slides with me and was a huge inspiration and resource for this talk. Thank you.